Here at Spectrum Health, we're working closely with our resident programs in internal medicine and pediatrics, as well as family medicine, to help them learn more about the direct link between food and health.
Blending the art of cooking with the science of medicine is very important because there's a lot of good research out there on the impact of healthy nutrition or better nutrition on health outcomes. But many healthcare providers have no idea how to work with that science of nutrition and actually translate it into healthy eating behaviors.
Students learn the nutritional science, they learn how to create healthy recipes, and they learn culinary skills. And when you combine the three, they can really translate that into their home kitchen.
It's important to bring medical students into the kitchen to show them cooking skills so they can become comfortable and confident themselves. Once they understand how easy it is to prepare a healthy meal from scratch at home, they then can turn around and bring that to the patients and empower the patients to do the same.
When patients hear me talk more candidly about diet and nutrition, they're actually pretty surprised. Most physicians don't get a ton of formal nutrition education, especially after medical school, and they're surprised to learn that I'm very interested in helping them achieve a healthy diet and learn how to live a healthier life.
We are seeing and treating diet-related disease and really need to find an innovative approach as to how we talk to patients about food and its direct link on their overall health.
When we bring a medical student into the kitchen, what we show them is practical skills they can use not only at home, but by teaching them practical skills on food preparation, we teach them also how simple it could be to work with fresh produce and fresh ingredients and plant-based ingredients.
I have several patients and their parents who ask me questions in the office about healthy eating and how to incorporate healthy foods in their diet, and I knew that this would help me get there.
Eating better food myself helps me to talk to my patients about diet and nutrition because I'm a better example for them.
We're really talking about behavior change, which can be very challenging for patients, and we know that it's hard to make changes in our own lives. Our ability to talk to medical students and help change their behavior, they're then more likely to talk to their patients about it as well.
Culinary medicine is not a gourmet cooking. It pairs the art of food preparation and the science of medicine. It is the practice of helping patients use nutrition and good cooking habits to restore and maintain health. It's about teaching the why and the how behind low-cost, convenient, health-promoting, and delicious home-cooked meals and healthy eating patterns. Culinary medicine offers a simple approach to understand how food and cooking relate to personal health, behavior, and healthcare goals. It is as much about learning which food reduce inflammation and promote melting of cholesterol plaques in our blood vessels as it is about how to properly slice the onion and cook food with rich flavors and enticing plate preparation. More importantly, culinary medicine offers individuals an opportunity to practice culinary skills and taste new recipes alongside with health education. And all of which is taught in a way that effectively translates to their own home kitchen. The objective is to educate about the powerful influence that food has on health and disease. The goal is to establish skills in preparing meals with nutritional benefits and develop the habit of being a smart consumer, someone who would always consider what follows after every swallows. The curriculum is designed not only for healthcare providers, but most importantly, for patients and their family. Culinary medicine is purely an evidence-based field of medicine. In fact, a growing number of medical schools in the United States are increasing the education provided to their students on clinical nutrition and bringing medical students in the teaching kitchen. As we speak, more and more medical practitioners and lifestyle medicine service providers are seeking the certification in culinary medicine. And now, the Philippine College of Lifestyle Medicine finally brings culinary medicine certification course in Asia. It is a program with a blended curriculum composing of online and in-person modules that anyone can finish between 6 to 12 months at their own pace. The online component will provide foundational knowledge in culinary skills, behavioral coaching, and clinical nutrition for specific group and specific disease. There will also be a remarkable emphasis on chronic disease prevention and reversal, such as diabetes, heart disease, dyslipidemia, basing on published evidences. Bottom line is, culinary medicine is a course that should be taken by anyone who has the risk or who already have the chronic disease, where the cost is mostly within the control of our lips. See the link, register, and get your kitchen ready.
All right, good afternoon, everyone, and thank you for joining us in this free webinar brought to you by the Asian Institute of Culinary Medicine. I'd like to thank all those who are joining us from Luzon, Visayas, Mindanao. There are also those who are joining us from Malaysia. We have also students from Singapore. We have students from Pakistan. We also have others from India and Indonesia. So the Asian Institute of Culinary Medicine is serving Asia, not only Asia, but we're starting to serve Nigeria as well. So this afternoon we'll be talking about fatty liver disease. But before that, I'd like to invite you to visit our website. If you haven't gone through the website yet, this is the new face of our website. Still the same, www.culinarymd.org. So we recently migrated to a new hosting platform. So the schedule for today is dietary intervention to reverse fatty liver disease. If you were with us last Sunday, we talked about salads, wraps, and dressings, and how can it benefit you? What are the ingredients, that we are supposed to be looking for, that we wanted to add, specifically add value to the salads that we're eating. So on October 20th, we'll be talking about diabetes as a disease of fat toxicity, and that will be the last webinar for the month of October. So if you haven't posted your pre-order for the second edition of the Culinary Medicine Handbook, you can just scan the QR code, and so you can post the order so you can get the pre-order rate. On the edition 2, if you are able to access the first edition, the second edition will give you all the updated studies about those kinds of diseases, of course, updated interventions, and then we'll have a new set of recipes, combined Filipino and Asian recipes. So if you are holding the first edition of Culinary Medicine Handbook, then you can find the topic for today on Chapter 9. That will be Chapter 9, page 229. All right, so we know that in lifestyle medicine, nutrition plays a huge role in terms of our management, and then culinary medicine is one of the novel modalities that we use to implement nutrition prescription. So what we want to happen in culinary medicine is to translate those nutrition prescription onto the plates of your patients. So if you're new here in this webinar, you're welcome, very much welcome. And when we say culinary medicine, this is actually combining nutrition knowledge and culinary skills to achieve optimal health management. So we mix culinary skills and medical science in the practice of medicine. All right, so I think we're ready to dive in. We'll be talking about fatty liver disease. In fact, there's a new name already, that we use nomenclature for fatty liver disease. It's kind of long. That's why I'm still comfortable using fatty liver disease, because that's what our patients would actually recall. So now it's called metabolic dysfunction associated steatotic liver disease. So it's long, and it's more of scientific name. So anyway, we'll talk about fatty liver disease that's not related to alcohol consumption. So I'll be using the reference published by the AACE. So this is the American Association of Clinical Endocrinology Clinical Practice Guideline for the management of non-alcoholic fatty liver disease, and we will be dealing more on the non-pharmacologic management. So again, now if you can see on the screen, it's still NAFLD, but now it's called muscle, no? But they mean actually the same thing. So if this is the normal liver, what happens is that the liver is infiltrated with fats. When it becomes infiltrated with fats, we call it the hepatic steatosis, right? So, and now we can see that about 25% to 30% of the population, general population, they actually have fatty liver disease or hepatic steatosis. And then it's also sad because about a significant percentage of those who have fatty liver disease may develop the aggressive form of fatty liver disease, which is called the steatohepatitis. And then those who have steatohepatitis may actually progress to develop cirrhosis of the liver or hepatocellular carcinoma in just a matter of 5 to 10 years. Now, remember, there are many of us, in the general population who may have fatty liver disease. So usually it's an incidental finding when we request for ultrasound, abdominal ultrasound. Incidentally, we find that there's a fatty liver disease, right? And usually this is not aggressively managed. So we just give supplementation to patients. We just advise them avoid alcohol or manage diabetes, but not intentionally providing intervention for this patient so that they reverse fatty liver disease. So our goal in culinary medicine and in lifestyle medicine is the moment there's a diagnosis of fatty liver disease, we wanted to reverse it the soonest we can. Why? Because we wouldn't know who among those who have fatty liver disease may have the aggressive form, which is steatohepatitis, who will be progressing to develop cirrhosis of the liver and then or hepatocellular carcinoma, right? So we want the only way for us to know who among these people who have fatty liver disease may have steatohepatitis, which is the aggressive form. The only way to know that is biopsy, and that's too invasive, right? So our goal is to treat everyone with fatty liver disease with a risk of developing steatohepatitis, and so we want to reverse it through lifestyle intervention. So when you look at the burden of fatty liver disease, Philippines is there. We're included. In fact, 62.6% of liver-related deaths is found in Asia-Pacific region. This is composed of at least 55 countries. So like I've mentioned earlier, here you will see that the simple fatty liver disease can progress to steatohepatitis in about 20 to 25% of cases. And nearly 20% of those who have steatohepatitis will develop fibrosis and cirrhosis. And in patients with cirrhosis, there is a cumulative incidence of hepatocellular carcinoma of about 2.5 to 12% over the course of 3 to 7 years. So we want to intervene the soonest we can. We want to reverse liver disease. So what's the cause? For us to intervene, for us to manage, we have to know what's causing the fatty liver, the infiltration of fats in the liver. There are 3 known causes for this. First is the de novo lipogenesis. That means there is production of fats in the liver because of too much intake of sugar, too much intake of calories, too much intake of high fructose corn syrup. We're drinking our calories, we're drinking our sugar. Okay, that's one of the causes. Next cause is the fatty acids, the fats that we eat from food. And then the third is actually the fats, the excess fats that's released from our body because we have too much adiposity. That means overweight or obesity. Okay, again, 3 factors. First is too much intake of your calorie from sugar intake, or specifically refined sugar, and then fats from the diet, and then the excess fats in your body. All right, so we're good with the 3. Now we know the cause. Then, of course, we know how to intervene. So look at this. This is an intervention that was a research, actually, randomized clinical trial with the recipient here or the participants here were adolescent boys. So they were placed into low free sugar diet compared to the usual diet. And then what they found is just after 8 weeks in low sugar diet or low or in free sugar diet, there was a significant improvement in the fatty liver in the infiltration of fats in the liver. All right. So with this large amount of data, available data, we needed to actually campaign, and tell the public, inform the public about the health risk of eating too much sugar. So when you read the nutrition labels, you can see they're added sugar, right? So you have to be watchful, with regards to added sugar and of course, concentrated sugars as well. So here, how about dietary fats? Look at these patients who were placed into low-fat diet in 2 weeks' time, right? In a period of 2 weeks, where patients were placed into low-fat diet. Now, how do we say this is low-fat diet? So usually we're given in a total caloric diet for the entire day, we're usually taking 20 to 35% of the overall calorie coming from fat. So 35 is at the upper limit, 20 is at the lower limit. So that's low fat diets. And here patients were placed even lower at 16%. Now I'll give you example. The usual McDonald's or the usual Jollibee Chicken Joy. Okay, that's how they call it in the Philippines. They call it Chicken Joy or the McDonald's chicken. Usually, when you look at the fat profile, you will find out that it's about 49.7% fat, right? In just one meal, you're getting over 40% of fat in just one meal. That's actually far above the upper limit of what's recommended for the daily fat intake, right? So we wanted to take like 20%, not over 35%. But if patients have fatty liver disease, we want them to have low fat diet. Why? Because in this publication, they found out that there is a decrease, in fat infiltration in the liver when you put them in a low fat diet. So it actually also positively impacts insulin sensitivity. We know that intracellular fat causes insulin resistance, right? And among patients with fatty liver disease, we know that diabetes type 2 increases the progression, of the development of fibrosis among patients with fatty liver disease. So we wanted to manage overweight. We wanted to manage adiposity, right? So here, if you review this is the pathophysiology. That's how fatty liver is being developed. So how it started, it's because of the food that we eat. It's because we don't exercise, and it's because of the too much fat that we have. We have too much cellulites, too much fat under your skin, So there's excessive fat production in the body. So there's a lot of free fatty acids. And so your liver eventually develops infiltration, and eventually there is a formation of fibrosis, and then patients may develop cirrhosis, and we want to cut this from here, right? So how do we manage? They said, look at this. The major modifying factor for this pathophysiology, the development of fatty liver disease is number one, of course, genes may play a role. Your gut microbiome, what are you feeding? What are you giving to your gut? And then the environmental, of course, the dietary intake of fat, saturated fat. So this is the intervention for fatty liver disease. It's still NAFLD. Again, like I mentioned, now it's called muscle. You will see here that even in primary care setup, what they're trying to implement here is what lifestyle changes. And what is the lifestyle change that they're trying to implement? Weight management, including what? You have to manage dietary habits. So this is where culinary medicine will really play a huge role. You look at the dietary plans, look at the barriers. And since this is more of food and weight loss program, we're thinking of how we can help patients to change their eating behavior. So at the end of the day, eating is not just they wanted to eat, So it's a behavior. And in everything that we eat, we change one eating behavior at a time. You may be good at not eating meat anymore, but you're still you're still drinking sugary beverages, right? So you might be good of not eating in Jollibee or McDonald's anymore, but you can't let go of your chocolates, right? So these are different behaviors. So we wanted to help patients to change one behavior, one eating behavior at a time. And it's always a continuous process because your environment, your situation, your choices actually is determined by the availability of the resources that you have. Like, for example, what influences you to decide that on the food that you ate for lunch, right? It's Sunday. So where were you Sunday? You might be in the mall, and in the mall there's a lot of choices, right? So your choice architecture was actually impacted by the environment where you're at by the time you decide what to eat, correct? So that's why it keeps changing. So what we wanted to happen is for patients to have a sustainable behavior, eating a healthy eating behavior, is for them to understand why they needed to eat healthier, why we needed to place them into low fat diet in particular if this is patients with fatty liver disease. Now going back to the guidelines, I'd like you to focus your eyes in here. So here it's telling us that we have to know who among those patients are considered high risk. Those who are obese, those who have metabolic syndrome, those who have pre-diabetes or type 2 diabetes with fatty liver in their ultrasound, and they have persistent increase in the liver enzymes. That means that's your SGPT and then your SGOT over 6 months. That means it's consistently high. They are the ones who are considered high risk. That means they can advance into fibrosis. And we know when there's fibrosis, they're heading towards cirrhosis of the liver, right? So we consider them as high risk. Take note of that. So unfortunately, when you look at the liver enzymes, we thought, depending on the labs, usually you will see they're 50 or over 50, right? So 53, 57, it's still considered normal, the upper limit. But what's true normal in terms of ALT levels? So for female, it shouldn't be above 25. And for males, the upper limit should be 33. So do not be happy if you see 40s in your labs, right? So the true normal for female should be less than 25, and for male, it shouldn't be over 33. And take note of this. It's also important to remember that in persons, and this can always happen, that in persons with fatty liver disease and even normal levels of their SGPTs and SGOT can still have significant steatohepatitis. Remember, steatohepatitis is the aggressive form of fatty liver disease and develop advanced fibrosis or cirrhosis, right? So I would have patients with normal SGPT and normal SGOTs, but they just have fatty liver disease by ultrasound. That's all they have. They don't have symptoms, blood works normal. They just have fatty liver disease by ultrasound. And then I would use this checklist here. My patient has type 2 diabetes, you know, they have hepatic steatosis, meaning they have fatty liver disease in ultrasound, but then they have normal aminotransferase, right? So it doesn't follow that if you have normal aminotransferase, you're not at risk, you know, to develop the advanced form of fatty liver disease or may even progress to developing cirrhosis of the liver. I would have patients where I request FibroScan, and voila, you will see there they have early signs of fibrosis with normal liver enzymes, right? So the take-home lesson here is whenever you see fatty liver in ultrasound, even with normal aminotransferases, you have to reverse them, you know, the soonest we can, because we don't want them to develop advanced fibrosis. And take note, type 2 diabetes is the major driver of disease progression for the liver. So how do you manage fatty liver disease? We manage the blood sugar of the patient. We need to help the patient achieve type 2 diabetes remission. Otherwise, we cannot help them reverse their fatty liver disease and even their risk to develop fibrosis. Take note, here, while the disease progression rate is relatively slow in most people, the progression may be faster in patients with type 2 diabetes and patients who are obese. So remember, approximately 1/3 of these patients may progress to NASH or the aggressive form of fatty liver disease and develop fibrosis, cirrhosis, and even liver failure. So just to show you the new nomenclature that we use now, NAFLD is now termed as muscle or metabolic dysfunction associated steatotic liver disease. It's long, right? That's why I just still call it fatty liver disease. My patients won't be able to follow. They can't remember. Anyway, we know lifestyle as the pathophysiologic factor for fatty liver disease. And so this is where we actually intervene. So what do we want to establish? So another one here is do not forget that non-alcoholic or muscle or non-alcoholic fatty liver disease, meaning you don't have a significant intake of alcohol. Otherwise, if you have significant intake of alcohol, then that could be alcohol-related fatty liver disease. And again, we know that type 2 diabetes is the major driver for this progression. And this is even increased when there is metabolic syndrome, right? And then insulin resistance. And we know that the first line of therapy for fatty liver disease, according to the clinical practice guideline, is lifestyle change, lifestyle intervention. So it's nutritional therapy and physical activity is the first line therapy. What is ABCD? Adiposity-based chronic disease and related complications, including fatty liver disease. So we can only achieve this with caloric deficit, right? Because we wanted to achieve the ideal weight. So it says here, if you have fatty liver disease, we wanted the goal is to have at least 5% weight loss. Ideally, achieve 10% weight loss. And our goal here is to get rid of simple sugars that we can find in beverages and foods, and where you can find high fructose corn syrup. So remember simple sugars, so you can usually find this in pastries. So the moment you use table sugar, that's simple sugar already. Pastries, salads with cream, no? And then sweetened beverages, soft drinks, for example, and any other fruit-based sweetened beverages. And then you have to, this is the time you have to read the labels. Anything that has high fructose corn syrup can actually give load to your liver and produce de novo lipogenesis, right? And increase your risk of developing fatty liver disease. So we wanted to achieve calorie-restricted diet, rich in fruits and vegetables, whole grains, and then low fat dairy, low in saturated fat. And then how much of a fat are we going to give patients with fatty liver disease? Low fat diet, 20% of the calorie, right? Or 16, usually I give 15%. Because it's the same thing we give for diabetes type 2, so they can achieve remission. So for fatty liver disease, it's still low-fat diet. So how do you know if it's low or high, if the food that you're taking has low or high? You can easily ask Mr. Google, no? Just type in there, fried chicken nutrition facts, right? Or cashew nuts nutrition facts. Can you type in there? Can you ask Mr. Google? Cashew nuts nutrition facts. You realize that 1 cup of cashew can give you over 700 calories. And then over 50% of that is actually fat, you know, and many other nuts actually may contain 80% fats. That's why even with nuts, we're so careful among patients with fatty liver disease, okay? So here, if you look at this pyramid, this is very nicely put, you know. It's saying when you achieve 3% weight loss with the use of this intervention, that means low calorie diet, we need to exercise, you know. So when you achieve 3% weight loss, the fatty changes in the liver improves as early as 2 weeks. That's what they found in the literature, as early as 2 weeks. And then if you achieve about 5% of weight loss, in fact, the inflammation and then the ballooning is also reversing. And then there's resolution of the steatohepatitis, and there's even resolution of fibrosis at 10% weight loss. So the only remedy, the only way to reverse fatty liver disease is lifestyle intervention. No drug can actually reverse fatty liver disease. There are proven drugs that can help patients with steatohepatitis already, you know, but your goal to reverse fatty liver disease is through hypocaloric diet. Remove refined sugar from the diet, remove high fructose corn syrup. Now, this is where we're talking about intensive therapeutic lifestyle change, right? Because your goal is reversal. If your goal is only prevention, then you can be, you can tell your patient, oh yeah, you can eat this at some time. But if your goal is reversal, then it should be intensive. Otherwise, we won't be able to achieve reversal. It's the same thing with diabetes. If you want reversal or reversal of prediabetes or remission of prediabetes, which will be the next topic, that will be on October 20th, then it should be intensive therapeutic lifestyle change. And that's what we're talking about now. All right. So that's why in order to achieve this is where we calculate the calorie. This is where you really calculate how much of fat you will allow your patient to take. Okay, so it's only what 20% below. So it should be low fat diet. So look for, let's say, if you eat your salads, look for low fat dressing. If you eat anything, when you put anything on your plate, you have to make sure that the composition of your plate will be like below 20% fat. All right. So another thing that I wanted to emphasize here is the benefit that we can get from probiotics. Now, in this review of the meta-analysis of randomized clinical trials, so this is higher level of evidence, they were able to prove that probiotics can potentially improve the liver function, even among patients with liver cirrhosis already. Okay, so why? Earlier, if you remember, with the pathophysiology of fatty liver disease, we mentioned about the gut microbiome, correct? So we wanted to address the inflammation that's going on. Well, we know that if you are obese, if you're overweight, we know that you are having what? Low-grade chronic inflammation. Low-grade chronic inflammation. And so that environment is actually beneficial for tumors, for heart disease, for diabetes, for kidney disease, for fatty liver disease. That's why we wanted to reverse that, right? And so probiotics is also one of those that can help you get rid of inflammation that's contributed by the gut, the leaking in the gut. So we know that in the gut, whenever we eat something that's high in fiber and you have your good bacteria right there, they're so happy, right? These are the saccharolytic bacteria. They increase in number. They actually improve the integrity of your gut. So there's no leaking of the bacteria from the gut. But whenever we eat something with animal protein or animal source, specifically those that have high heme iron source, heme iron, that means the blood that you get from the meat. So when we eat that, there's an increase in the proteolytic bacteria. So you'll see that in literature, the proteolytic bacteria will actually produce uremic toxins. And these uremic toxins will cause inflammation in the gut. So there's leaking, there's leaking of this proteolytic enzyme in the gut, and there the inflammation sets in. And so that's how your probiotic, they found out, can help patients even with cirrhosis of the liver. So again, probiotic induce favorable changes on the quality of life and gut flora among patients, even patients with cirrhosis of the liver. So that's why the conclusion here, there is a compelling evidence supporting the benefit of probiotics among patients with cirrhosis of the liver. So usually when you look at the doses, most of the studies will tell you that they were giving like 100 to 180 billion CFUs probiotics. So you can search for any brands that can give you that much. And then, you don't have to maintain this for life. Just give yourself good amount of probiotics and then feed them through the fibers you're eating. right? Through the fibers, because they eat fibers. That's how they actually replicate. But until you eat you eat animal-based sources, processed food, for example, canned goods, corned beef, for example, meatloaf, for example, it has really high saccharolytic bacteria. It will produce a lot of uremic toxins. And so this proteolytic bacteria will fight against the saccharolytic bacteria. It depends on how much you're eating. Let's say today you're predominantly eating animal-based products, then that means the probiotics will be, the good bacteria will be lower in number this time, right? So that's how we look at it. Okay. So in summary, we discussed about fatty liver disease, and it's estimated to affect a quarter of the world population, which includes Filipinos, because about 67% of liver-related deaths are found in the Asia Pacific region, with over 55 countries. Lifestyle modifications and management of type 2 diabetes, obesity, metabolic syndrome remain the cornerstone management for fatty liver disease. And pharmacotherapy is on the table in addition to lifestyle therapy, and this is for the aggressive form of fatty liver disease, which is called steatohepatitis. Okay? So I hope you learned something from the discussion this evening. So when we wanted to get rid of this kind of liver, look at this liver. The liver is supposed to be red, and then the surface should be soft. But look at this. This liver is infiltrated with fats, right? We wanted to reverse this. No drug can reverse this situation in the liver. This is how it literally looks like, and you can only see fatty liver in ultrasound, and it's black and white, but this is how it really looks like. So we wanted to reverse this situation. All right, so I hope to see you next time again. So that will be October 20th. So we'll be talking about diabetes, a disease of fat toxicity. That will be the last topic that we have for the month of October. So again, if you haven't posted your pre-order for the book, that's the QR code. Thank you so much, everyone, for joining me this afternoon.